Okay, so I'm going to talk about COVID and long COVID symptoms and possible mechanisms. So just to warn you now, there's quite a lot of slides. I felt it was easier to put information on slides where you could read it as well as me talking to you. So let me start off the slides. Okay. And okay, so COVID-19, what do we know about it? We know it's a SARS virus. That means it's a severe acute respiratory syndrome virus. It's a new strain not previously seen in humans, but there have been other SARS outbreaks in the past. So notably in 2002, 2003 in Hong Kong, there was a SARS outbreak. And COVID-19 is the name for this one. The level of symptoms is variable. So we've got asymptomatic up to severe, and severe COVID is defined by the level of respiratory support needed from simply oxygen in hospital to the use of a ventilator. So way back in March, that seems like another lifetime ago, data suggested then that about 1 in 5 people catching COVID would need hospital treatment. And the NHS has already anticipated that inpatients would need significant amounts of aftercare. Some estimates were around that around 50% of people hospitalized would need formal rehab services. And that could be long-term as well. And just to note as well that it's not just physical symptoms, there's also mental health difficulties too. Post-intensive care syndrome, I'll tell you a little bit more about that, and PTSD. So what are the effects? Nikki described some of these effects, and it's worth remembering that the effects of COVID-19 are multiple and individual. They can affect respiratory. Well, of course, respiratory is the first noticeable effect for many people: cardiovascular, renal, nervous system, musculoskeletal, metabolic systems, but also GI tract and the skin. There's a very nice little report, if you want to have a look at it, by the British Society for Immunology, and they talk about 4 groups of effects. So the first one is direct effects of viral infection, tissue damage. That can be around lungs, so fibrosis and scarring of lungs. If there are complications and it moves into pneumonia, which can have lasting damage as well, and sepsis and other conditions that can require recovery over months or be long-term conditions. And then another effect, excessive inflammation and subsequent damage, notably inflammation of the heart muscle, and also links to other inflammatory responses. So there's a lot of information here. Just to let you know, I have got a resources sheet. And this talk, the idea is it will be uploaded. So please don't feel you've got to write everything down, because there's a good chance you'll just be able to watch it again later. Okay, so we've covered direct effects and inflammation effects. Post-viral autoimmunity, this is really one that I wasn't terribly aware of. So worth noting that viral infections are a major trigger of autoimmunity. This is a complex picture. There's lots of ongoing work into how viruses affect those systems and maybe develop into other conditions, but it's worth noting that people may end up going through a viral infection and then other things happen after that. And then finally, complications emerging from the formation of blood clots. That can be in various tissues and organs, some of which will need critical attention. So what's long COVID? It's a bit it's an ability or inability to shake off the side effects after infection. So that there were a whole cohort of people noticing that they had ongoing symptoms for weeks or months after infection. The most common symptoms, some of these, I think most of these you told us about, Nikki. So fatigue and shortness of breath, difficulty in thinking or brain fog, chest pain, irregular or abnormal heart rhythm, and joint pain. And remember as well that the symptoms aren't linear or sequential. There's not a set pattern for these symptoms. They're variable, they can come and go. One disappears, another one appears. One disappears, another one reappears. So it's a real challenge for both medical professionals in diagnosing the condition and also for patients. I think, you know, as a patient, you want to know that the medical person you're talking to has an idea of what's happening to you, or at least can say, well, we're not quite sure, but we think it might be this. And then typical symptoms, I've got another list here. You can see it's really wide ranging. The most common one is fatigue. 98% of people reported fatigue, and then muscle ache, shortness of breath and headache, but other ones as well. And there are psychological complications to suffering long COVID, emotional distress of that, fear, stigmatization, quality of life is affected, of course, PTSD, and this might apply more to those who have been admitted to intensive care units. The challenges of public messaging being that COVID is a mild illness and there's a recovery time of about 2 weeks. I'd imagine that's really challenging. And it's not always confirmed by an antibody test. And as Nikki said, the severity of symptoms after being really well and healthy beforehand. If we think about how symptoms are being assessed and monitored, then you may have come across this. It's called the Zoe app. It's an app you can find on your phone to download. It's a symptom tracker. It's a COVID symptom tracker. And as a result of that app, then the people who are putting that together, King's College London, Guy's and St Thomas's Hospital, the Biomedical Research Centre and healthcare startup Zoe, they've grouped symptoms together in these 6 groupings, so clusters, symptom clusters. Flu, and you can read through these: flu-like cluster with no fever, and then with fever, a GI cluster, a severe level 1 cluster, and then level 2 and level 3. So the clusters are characterized by those symptoms. So the app is one way to try and work out how many people are catching coronavirus and how many people are suffering from long COVID. And many prevalent studies are ongoing. The Zoe app is one, but it only provides, of course, somewhat limited data, because not everyone has a phone, not everyone knows the app is there, not everyone is going to take part in it. So it's quite a limited data set. However, from that symptom tracker, the data that they've collected so far is that 1 in 7 of people catching of symptomatic COVID, that's a better description, isn't it, rather than just catching COVID, would be ill for at least 4 weeks, 1 in 20 for 8 weeks, and 1 in 45 for 12 weeks. However, I should add there that other data suggests that numbers of long COVID, the proportion of numbers of people with long COVID is higher than that. So really this is a kind of estimate from this particular source for now. In the NHS, they are moving now to set up 40 specialist clinics around the country, COVID clinics. And as part of that service, then people will be seen by respiratory physicians with input from physiotherapists, infection doctors, psychologists, cardiologists, and neurologists. So it's really, I think, helpful, a good sign to see that a somewhat integrated approach is being taken. If we look at what else is happening treatment-wise, then a good place to look is what's happening in the armed forces. So the Defence Medical Services, which cover medical services for the armed forces, have set up multidisciplinary teams, and their personnel who are experiencing coronavirus symptoms over a longer period are brought in for an assessment. They go into a 2-week inpatient intensive, followed by a 3-month follow-up. So I can show you a little bit more about what that looks like. Early intervention. So this slide is almost all from what's happening within the Defence Medical Services. Unfortunately, not the NHS. I'm sure the NHS would like to do this, but this is what's happening for armed forces personnel. There is some, whenever possible, early intervention, and to try to stress to personnel that they need to take significant periods of rest as people were experiencing peaks and troughs of energy. And that's, again, very much what you said, Nikki, about rest being so important. I've also put in brackets there steroid treatment for those that are hospitalised, and that's the current situation within the NHS. So if you are admitted with coronavirus into hospital, you will most likely be given a steroid treatment to help reduce the symptoms and to prevent you going into a severe coronavirus condition where you may need ventilation. And that seems to be working successfully. So just to flag that up as an early intervention. Okay, so for the Defence Medical Services, they are running a 2-week course where personnel are staying in a residential environment. They're assessed, and there's general rehab, pulmonary and cardiac, and so on. It's seen as very important that they receive education. And I thought this was interesting, education on pacing. And so finding, what they can and can't do and how to structure their time to do what they can and not overdo things. Nutrition, psychology, relaxation, that's interesting, and mindfulness. Yeah, so great. They've got some useful psychological tools there as well. And then at the 3-month interval, I haven't got anything in that column at the moment because this is all very new, and I think there isn't really enough evidence, or not enough people have gone through to the 3-month stage. So when I watched the information that was out there on this, there wasn't really much at the 3-month stage yet. Okay, so long COVID mechanisms. There's recent evidence to show that there are at least 4, there may be more syndromes, and I'll run through what those are. Really, this is an evolving picture. So this is kind of a snapshot for now. It may change in the future. The first one, I guess, is really relatively well known about post-intensive care syndrome for people that go through that experience. It's a combination of cognitive and psychological and physical impairment. There's various issues that occur from loss of strength following immobilization, psychological impacts as well, anxiety, depression, delirium, PTSD, and cognitive impairment. So a whole range of quite challenging issues, some which might be longer term than others. And another mechanism is post-viral fatigue syndrome, ongoing fatigue for 2 to 3 months or more post-viral infection. And I put down a couple of notes there from some information resulting from the SARS outbreak in Hong Kong, indicating that one possible route for the virus may be through the blood-brain barrier into the hypothalamus via the olfactory nerve. And there's a suggestion that this could be a reason for the anosmia, the smell-taste impacts in coronavirus that people noted quite early on. And then a build-up of anti-inflammatory agents leading to autonomic dysfunction. So this was things that were noted, in particular, acute high fever, changes to the regulation of sleep-wake cycles, cognitive dysfunction, and profound unremitting anergia, so a complete exhaustion. And I put down there this term, post-exertional neuroimmune exhaustion. It's worth reminding ourselves at this point that the sort of exhaustion which is severe, and it can occur even after small, what would be normal activities. So it's not even, going out for a walk. It may be talking to somebody for a while. It may be getting up to make a cup of tea. So the exhaustion level can be extreme and severe. And then a third mechanism, permanent organ damage. Lungs are susceptible, of course, can be heart muscle damage too, perhaps effects on the brain. I've got some data there. 70% had impairment in one or more organ after 4 months. 2/3 of participants had impairment in one or more organ system, and then 1/4 of individuals with multi-organ impairment. And then the last mechanism, I'm not quite sure, but I suspect this might be, people didn't fit into any of the other previous ones, so this is the fourth one, long-term COVID syndrome or post-COVID-19 syndrome. Signs and symptoms that develop or are occurring after an infection consistent with COVID-19 and continue for more than 12 weeks. Presenting as clusters of symptoms, sometimes overlapping, which fluctuate and change over time and can affect any system in the body. And this syndrome may be considered before 12 weeks, but then there's a possibility of other underlying disease which may also need to be assessed at the same time. So those are the current thoughts on the mechanisms involved in long COVID, as opposed to coronavirus itself, just the shorter term acute illness. I've got a couple of slides now where it's starting to take us into the breakout sessions, where we're thinking about what we might be able to do in yoga therapy. What strategies might we think about using? Is it a multidisciplinary approach, or is it a standalone approach? Yoga therapy is in general community-based, online or in person, to provide support. Are we thinking about group activities with individual adjustment or individual approaches? Are we thinking about regulation of the autonomic nervous system and looking at how to affect the immune system and the inflammatory responses? Are we thinking about supporting people in developing their self-management skills? And we know that yoga is low cost and low tech, but high value, and it has immediate effects. What else do we know from our yoga therapy work? This might be research or personal experience, or experience of other people we know that we're working with. We know that individual assessment is important. Each person is different. Perhaps we're thinking about levels of activity, how to manage those peaks and troughs of fatigue and then energy to do things, so managing those. How to reduce fear and frustration and anger. Breath as an individual feedback to exertion. Learning self-management techniques takes time. How can we allow for that time? little and often to help people learn these things, and needing encouragement, perhaps a group dynamic, finding a regular practice, and multidisciplinary approaches as well. So I've just thrown those thoughts down. I'm hoping that you're going to have other thoughts around that, as well as things that you may know about, or you have tried, or you've talked to other people and used with clients with respect to their COVID and long COVID symptoms. So this is the final slide before we go to the breakout groups. It's worth noting there have been some very recent changes as far as NICE guidance on ME and chronic fatigue syndrome. So there was a recent change suggested on the 10th of November. A draft guideline was put forward for ME and chronic fatigue syndrome. The draft guideline states that there's no one-size-fits-all approach to managing symptoms. It stresses the need for a tailored, individualized approach to care. And formerly, it was accepted practice that if you had ME or chronic fatigue syndrome, that you would probably be given a graded exercise therapy approach. And this has now been, the guidance has now been changed in draft form, and graded exercise therapy should not be offered for the treatment of ME, chronic fatigue syndrome, instead using something called an energy envelope. And also there's emphasis that CBT is not a treatment or a cure. It can be a supportive therapy. And again, that's a significant change. Okay, so I'm going to move off the slides. Thank you for bearing with me as we went through all of those slides. Okay, our next section is breakout groups. So I'm just going to end the recording here.